you started, my name is Lindsay Covington. I'm the Director of Communications and Community Engagement here at HCA Florida Lake City Hospital. We're excited today to do our second HealthCARES educational series. We have Dr. Vazquez with us today, and she's going to talk about abdominal wall hernias. I do want to say that it looks like we have a full room here today with our staff and community members, so thank you all for joining us in person. We're also doing a Facebook Live, so hello everybody who's on Facebook Live. We appreciate you joining in and viewing us today. So I'm going to go ahead and turn it over to Dr. Vazquez, and she's going to take it over from here.
All right, thank you everybody for coming. My name is Dr. Vazquez. I'm one of the general surgeons with HCA Florida Lake City Surgical Specialist. As you can see, we have an office right here in town, pretty close to the hospital as well. Dr. Wong, he is my partner. We are two surgeons in this practice, and today we are going to go ahead and start, and we're going to talk about hernias and understanding them. So this is our second educational series, and we have plenty of them to go. So first and foremost, a disclosure statement. I have no financial disclosures to report, and I am an HCA employee. So chances are that you have heard of a hernia, or what is a hernia? Maybe your primary care physician also spoke to you about a hernia, or maybe one of your loved ones have also had a hernia. So let's see. So first, do you know what's behind that bulge? Because as we all know, a hernia is some kind of a bulge. Do you really know what's behind that bulge and what to do about it? So that's why we're here today, to talk about what to do with this bulge, when to get concerned, and who to attend to. So let's take a look. First, we have all of our organs in our body are, let's see if we can press play. The organs in our body are covered with muscles, tissues, hard core tissues that keep all of the organs in the inside. One very important tissue is right here, the fascia. So the muscles are on the side, and this white tissue is called fascia. That's a tissue that keeps all the organs in place. So when we have either a disruption or a weakness or maybe an incision from prior surgeries, that fascia or that muscle can become weak, also with time and with age. And once that becomes very weak, organs can protrude through that. Therefore, a hernia. So technically, what's a hernia? A hernia is basically a hole in your fascia, a hole in the muscle tissue, that then the organs can creep out from the inside of your abdomen and and create trouble. We can have different types of hernia that we will be able to discuss today and kind of learn a little bit from them. Very commonly, we see the umbilical hernia. Umbilical hernias are very much congenital. A lot of kids have it. It's because the umbilical cord was present there when we were babies. So by default, we have a little bit of a weakness in that area. So with time, coughing, sneezing, weight gain, and everything, that tissue becomes more and more weak, therefore having a hernia. So where are other hernias located? So in your lower chest, through your diaphragm, you can have what is called a hiatal hernia. The hiatal hernia is a little bit more complicated. It is not part of your abdominal wall hernia, but we can also discuss that a little bit. In your groin, through your abdominal wall, sometimes the small intestine or any other organ, like the colon, the appendix, even the bladder, can grow through the inguinal canal down into the scrotum, and it's mostly on men. Also along the front midline of the abdomen. And also through former incisions from prior surgery. Yes, we can fix surgery, we can fix hernias with surgery, but every time that we cut through the tissue, we will make it by default a little weaker, creating a risk of having a hernia in that point. So hiatal hernia, about half of the people over the age of 50 might experience or will experience a hiatal hernia. So this is usually the most common presentation of a hiatal hernia. It's usually either a middle-aged man, obese, chronic cough, COPD, maybe chronic allergies, a lot of sneezing, anything that will increase your intra-abdominal pressure. You can see the stomach going through the diaphragm into the chest, so like into your that's a hyohernia. So in this case, the patient will not feel, not see, or see any bulge or anything. So a patient might not even know they have a hyohernia. So what will they have? They will have symptoms of acid reflux. Because the stomach is going into the chest, you can have symptoms of GERD, chronic cough in the morning, just worsening acid reflux. In this case, these hernias are a little bit more complex to repair, but it's the same technique basically. Returning the organ down to its anatomical position and creating the defect. Also, umbilical hernias, very commonly, most umbilical hernias are congenital. They usually regress with time, like when you're either 3 or 4 years old, like the umbilical area will continue to close until the hernia just goes away. Or you can also present hernias from heavy lifting, your work, if you do a lot of heavy machinery and stuff like that, you can have, because you already have a weakness in that area from the belly button, you can have a hernia in that site. So anything that increases the abdominal pressure can lead to an umbilical hernia. Inguinal hernias are very common. It is 75% of all the hernias. It is usually in men, because in men, they had, when they were babies, they had their testicles in their abdomen. So the testicles, when they move down from the abdominal cavity into the scrotum, they go through this area where is the inguinal ring, where they can have like the spermatic cord and the vessels down running into the scrotum. Because they already have that area and that space, the intestines can go down through the hernia sac into the scrotum usually, but they can feel that bulge. So it's most commonly in men. So yes, we love to do surgeries. As a general surgeon, we also let the patients know to fix a hernia, I will still increase your chances of having a hernia in the future, because any incision can be a risk factor for having a weaker tissue. So incisional hernias, they weaken over time as well. So anywhere where you have an incision or the tissues were cut, you can have a higher risk of developing a hernia. And then you will have like that bulge in the hernia site or in the incision site. They can be small, like these, or they can be pretty complex. With time, weight gain, aging, makes the tissues weaker and weaker, creating worsening defects. So patients always go to the clinic and they say, well, their primary care physician said I had a hernia, so how serious is this hernia, or what should I do about this hernia? So the seriousness of the hernia, we kind of have to see the ups and downs, or how bad is your hernia? How big is it? Because if you have a hole, you're gonna forever have a hole. The hole will not fix itself, right? So the hernia will not fix itself, even if you stop doing heavy lifting or just maintain, bedridden, it's still going to be there. So the hernia will not get fixed unless you fix it. So most are not serious if they are small, reducible, the bulge is pretty small. Most people don't even know they have a hernia. They're pretty asymptomatic. But they can be pretty serious. They become serious over time because of the expanse, or the bigger, the older you get, the weaker your tissues. So, or the more weight you gain, the bigger the hernia is gonna be because of the pressure. So once the intestines get caught in the hernia, either in your belly button or in your inguinal region or from your incision of your prior surgeries, if the intestines get caught in there or any other organ, it will become severely tender and that tissue can die. That's when it becomes an emergency. So in severe cases, when the tissue dies, then you would have to be rushed into the operating room. We would have to fix your hernia, but sometimes we have to either resect the portion that is ischemic or dead. So the truth of it is, most of the time, surgical repair is warranted, either sooner or later. So what are these symptoms? So not every hernia is symptomatic. You can have a small, tiny belly button hernia and not even know you have it. A lot of females also have small, tiny inguinal hernias that they have no idea. So if you do have symptoms of it, you will feel a bulge, small tiny bulge in your groin, or maybe a bulge in your belly button. Again, the hiatal hernia, you will not feel or you will not see a bulge because it's like deep in your diaphragm. And when you have that bulge that comes out, if you have pressure in the area or pain, that's when your hernia is mainly just stuck in the hole. So when it does become stuck, if the intestine can go into the hernia, like basically into the hole, and can come back into the abdominal cavity, then that should be okay. If it gets stuck and the intestine becomes strangulated, that's an emergency. You should definitely seek medical attention. So in a physical exam, these would be like signs of strangulation. The small tiny lump or the bulge will become red, very tender, will become warm, because underneath that skin, the tissue that is strangulated is slowly getting inflamed, infected, and dying. You can have very common symptoms like redness around the incision, very tender to touch. So what are the risk factors? So patients usually come into the hospital or to the clinic and say, I think I have this hernia, and what could have I done to avoid it? Sometimes it's hard to say because hernias can also be genetic. If you have like a genetic disease in your tissues that you just have more weaker tissues, then you're at higher risk for developing a hernia. But sometimes you have these risk factors. The more weight you gain, the higher risk you have of having a hernia. Because if you can imagine, in the inside we also have fat that covers our organs, that creates like a cushion and kind of like protection. The more you gain weight, the inside fat also grows. So the higher the pressure inside of your abdomen. So more pressure that abdominal wall needs to contain. So if you cough, if you sneeze, the more weight you gain, the more pressure you put on the abdominal wall. So the higher risk of having a hernia. People with chronic allergies or chronic cough can also develop hernias just because of the pressure. Chronic constipation leads to a lot of straining. The same concept. Also, we see this a lot. If we do see a young person having a hernia, it's usually because they work in an environment that they have to do a lot of heavy lifting. And if you don't have like the exact posture or, like I'm not sure, to do heavy lifting with your legs rather than with your abdominal cavity or abdominal wall, then you can develop mainly inguinal hernias. And these are usually the younger, working, kind of slim, not morbidly obese patients that we see with hernias. Prior surgeries, like we discussed earlier, any type of surgical intervention can lead to a weaker tissue. And obviously pregnancy. Pregnancy, if you can imagine, like that is definitely, it's like gaining 80 pounds in 9 months and then losing it back up. So the amount of force in the tissue needs to be also stretched and have all that pressure for all that time can create definitely hernias. So if you do have a hernia, when should you worry about it? Obviously, it's not an emergency until it becomes one. So if you do have an asymptomatic hernia or a small tiny hernia, you should definitely worry about it when it is painful. So any hernia that is painful, it's worth visiting your healthcare provider. Because it's either getting bigger, it's getting caught more often, or it's just getting a little bit too symptomatic. So what if you do have a hernia and your hernia starts changing color? So now you usually, making a small tiny stop here, usually patients will go to the office and will also say, well, I was diagnosed with this hernia 2 years ago. And my doctor said that I could not do any heavy lifting whatsoever. And since then, I've stopped working out and I've gained 30 pounds. So now my hernia is worse. So basically, when a patient comes into the office and tells us that they have a hernia, we would say, continue doing your daily activities, your normal daily activities. When it starts becoming symptomatic, come see us. Because you might have this hernia for a long time, and if it doesn't become symptomatic, it's not a problem. Patients will usually start either not exercising anymore because they think that their hernia is gonna get worse, not going to the gym, not doing their daily activities. So now they're limiting all their daily activities because they have a hernia. So then you'll see these patients gaining weight, creating a worse environment for the hernia, making it a little bit harder for the surgeon to fix it in the future. So if you do have a hernia, continue doing your daily activities. Once it's becoming painful, get your primary care physician to send a referral, obviously, to us so we can fix it for you. If you do have a hernia and it suddenly becomes symptomatic, painful, and it starts changing color, it's numb, now you're having nausea, vomiting, abdominal pain, you know something's bad. Now that you know that usually the small intestine is the one caught in the hernia, if your small intestine or your GI tract is a long garden hose, that garden hose gets kinked in the hernia, it's not the water or nothing is gonna go down. So everything's gonna come up, causing obstructive symptoms. This is an emergency. So how are these hernias diagnosed? Usually physical exam and a good history is plenty to diagnose a hernia. When the hernia is complex, like the ones that we saw with the incisional hernias from prior surgeries, then your surgeon might get a CT scan to either evaluate what type of organ is herniating, how big the hernia neck is, and how complex, if you have one, multiple, because that will change also our surgical approach. So what is the treatment for hernia? So the treatment for hernias can be either watch and wait versus surgery. If you're a 20-year-old lady that were just diagnosed with a small belly button hernia, that you have no idea, it's been asymptomatic, and you're planning to have babies next year, I would probably recommend not fixing your hernia right now. Once, because if it is asymptomatic, like you have no symptoms, just leave it alone. If you're planning to have babies in the future, you wouldn't repair a hernia to probably put a lot of pressure on it in the next coming months for a pregnancy. So it's kind of like a watch and wait versus like, yes, it was obstructed last week, we pushed it back in, it's very symptomatic, we should fix it. A hernia that is becoming bigger and bigger should also get fixed. Or a hernia that is limiting your lifestyle, you cannot work anymore because of your hernia pain, definitely needs to get fixed. So we fix it 3 ways. We can do robotics, which is kind of like what we're moving towards. Laparoscopic, which is also like the robotics except different instrumentation, and open hernias. If you come in through the emergency room, chances are with an obstructed hernia, chances are you're gonna get an open surgery because it is the only way sometimes we can get the intestine back into the abdominal cavity. And if the intestine is ischemic or not looking very well, we might have to do resection. So the benefits of robotic surgery, so the surgeon will sit in the console with the robot behind it or just coming over like right with the patient. So the benefits is less invasive, it's small incisions like the laparoscopic ones. It's less pain for the patient just because the movements are more precise and less traumatic. Better camera and better control of the instruments. So here's an example of a belly button hernia or a ventral hernia right on top of the abdominal wall. So just imagine if the head is on that side, the feet are here, and this on the top is the belly. So we're looking up towards the abdominal wall. So we see the hole, all this tissue needed to be taken down because usually that's where the bulge will be. We see the hole and we measure the hole, and that's when we decide if we're going to place what kind of mesh or what kind of repair. So in this case, the defect measured around 5 centimeters by 2. So first we would suture the hole, close the hole completely, and then in most of the cases we will place a mesh to also give that tissue some strength, and then close the tissue on top of the mesh. When we're able to, we would do that approach so the mesh would not even touch the intra-abdominal organs. This is another example. Here we would create, if the hole was right here, small tiny hole, that's an umbilical hernia, we would create a small tiny window of the tissue, get to the hole, close the hole, give the person an innie, right, by grabbing just a tiny bit of that tissue, then closing really, really tight, and then sandwiching that mesh underneath that tissue, and then closing again the window that we had created. Creating like the mesh right under the abdominal wall, but not completely on top of the abdominal wall so it won't touch the intestines. That would be an ideal repair. When it becomes to like the inguinal repairs, we can also do them robotically. Here, we're looking down into the patient's pelvis. You can see the hole right there. Again, we would create a small tiny window with the tissue, and then we would place the mesh, and we would sandwich it in there as well. And then we would close the peritoneum. That way the mesh, again, does not touch any of the intestines in the inside. Laparoscopic is mainly the same technique, but we would be standing right on top of, well, not on top of the patient, but right beside the patient, and just maneuvering the instruments instead of being in the console. And open inguinal hernias or open umbilical hernia repairs are basically just opening the skin. We would make a small incision right where the inguinal canal would be running. We would find the inguinal canal and the hernia sac, and we would place also a mesh. So this is a quick video. Let's see if we can play that. Of a open inguinal hernia repair. We would make a small incision after doing local, which is also good. Even if the patient is 95 years old, we could still do this surgery under just local anesthesia. Not every time the patient needs to be completely asleep. We would cut down through the tissue layers. Obviously, this is not 100% how it is, but we would find the hernia sac, that the insides of the hernia sac would usually contain small intestine or any other organ. We would push the intestine back into the belly, really, really tight, close that hernia sac, and then support this floor, like the inguinal canal floor. We would support it with a piece of mesh, would suture that mesh there so nothing else could come down through the hernia again. That would be the difference in the open versus robotic. In the robotic, we would place the mesh through the inside, and in the open, we would place the mesh through the outside. And umbilical hernia repair is very common as well. In pediatrics, this is basically what we would do every single day, open umbilical hernia repairs. So also a lot of patients would be, so what makes you decide if we are going to use mesh or not? Or, and I'm pretty sure anybody that watches TV have probably seen a lot of TV commercials about mesh recalls, about mesh complications. Should I use the mesh? Should I not? My primary care said that there was some mesh that was placed 10 years ago that it's under recall and I don't want any mesh. Well, the truth is that these commercials are definitely not new. These commercials are way, way old. And the mesh is like any other medical device. You know, it is, yes, it is a foreign body in your abdomen. So like any other loop recorder or pacemaker, it is basically, you know, something that it should not be in your belly, it should not be in your body, but it is still, it has grown and it has developed into way better tissue, better components for that tissue repair. And right now, mesh is basically what everybody has recommended. And after many, many clinical trials, we have reached to the same conclusions. The best way to fix a hernia is with a mesh. We have different mesh, a mesh that can be placed in contaminated fields, a mesh that can only be placed in safe, sterile fields. So the usual good candidate would be a non-smoker, right? Person that's non-smoker, non-diabetic, or is a diabetic, controlled diabetic, and an elective hernia repair, not a strangulated hernia. If it is an elective hernia repair, we would definitely place a mesh with low risk. If the patient comes in with a obstructive strangulated hernia with dead intestine, chances are you're not gonna get a mesh, because that mesh can get the risk of having contamination. So we also know that the mesh will decrease the risk of recurrence. So we have a lot of different mesh, the way they're made, the composition of the mesh. Some mesh are thinner than others, less basically bigger pores, smaller pores. So as a surgeon, the surgeon will, depending on the situation, we would be choosing the mesh to use. But we can use bigger mesh to create a bigger and a thicker, kind of more stable abdominal wall for bigger defects. So what are the potential complications of the hernia surgery? As any other surgery, there is a small risk of bleeding. There's also a small risk of wound infection. If the mesh becomes infected because it was placed in an infected field already, then you would need your mesh to be removed. Reactions to anesthesia as any other surgery, and most importantly also difficulty urinating after surgery. There might be also a situation that if, for example, a 75-year-old male comes for an inguinal hernia repair, if we're going to do it robotically, because the groin is very close to the bladder, we definitely want the bladder to be completely empty prior to doing surgery. So we would place a Foley during the procedure. If this patient already has difficulty urinating outside of the surgery, like in his house and he takes medications for his prostate, we can choose to leave the Foley for 1 or 2 days, because it's very well known that because of the area that we are working on, patients can have a little bit of retention for the first 1 or 2 days after surgery, also because of the anesthesia. And then 2 to 5% of patients report chronic groin pain after inguinal hernias, with or without mesh. There is a lot of debate over the mesh placement with having chronic groin pain. And we've seen that even if you don't get a mesh placed, you could still be one of these patients with chronic groin pain, and it's because of nerve damage while we're doing the surgery. So we have definitely big landmarks that we go and where not to go, so we avoid these nerves to avoid this complication. So what to expect post-op? If you are elected to have a outpatient procedure, like an elective hernia repair, then you would come in the morning, you would get your surgery, and you would leave the same day. It's completely outpatient, if elective. If you come in through the emergency room with an obstructive strangulated hernia, chances are you're not gonna leave the same day, because we would need to make sure that your intestines that were strangulated in there are still good, and that you're not being, not getting sicker and sicker with with the days. So also it depends on the size. So if you have a big hernia, you're gonna have more pain than the person that comes in to repair a smaller hernia. Usually inguinal hernia repairs are less painful than abdominal wall hernias. The umbilical hernias, if they are pretty decently big, like that 5x2 hernia, when we close it, it becomes like a little bit of a tension right there. And then how we place the mesh, sometimes we sew the mesh to the abdominal wall. That's also tender. But you won't be bedridden. You can go back to work in several days. You would be kind of like a sofa to the kitchen, sofa to the bathroom for the first couple of days. It'll be a little bit sore. Your abdomen will definitely be sore, but you would not be bedridden. And then definitely the most important, if you did come for a hernia and we are fixing your hernia, we would not want you to, have another hernia. So it's 6 weeks of definitely no heavy lifting. And this is like non-negotiable. It's like you cannot do any heavy lifting, because we know by default that the tissues take 4 to 6 weeks to completely heal in the inside. And what to do about the abdominal binder? Very common question too. The abdominal binder, if it is worn how it's supposed to be worn, it is good after surgery, because it will create also like another layer whenever you cough or sneeze after surgery. You'll see people like holding their abdomen or their surgical site. Very important, and it's also mainly for comfort. But I have seen patients that will just place it through here and then they can't breathe. That definitely not comfort. So if you wear it the way it's supposed to, it will definitely work. So what about this hernia belt? A lot of patients will also come into the office just saying, my primary care physician recommended this hernia belt. What should I do about it? So this works if you're in a bridging to surgery. If you working and the hernia pops out after certain hours of heavy lifting or after certain hours of being on your feet, then yes, a hernia belt might work. It relieves pain and relieves discomfort because it's kind of trying to push the either your intestines or any insides that's trying to come out. It is basically just trying to just keep it in there. After the surgery, you do not need this hernia belt. After surgery, it should be good to go. So other patients will come in from their primary care physician and they're saying, but what about this? The PCP sent me because I have this huge hernia in my belly. And it is like an alien that's trying to come out every time that I try to get out of bed or like try to sit up. Well, no, this is not a hernia. We know that a hernia is a hole. In this case, rectus diastasis that looks like that is basically the muscles. The muscles have split a little bit, just kind of separated itself from the fascia. The fascia, that white line, white tissue, very, very tough tissue, kind of gets a little bit wider, mainly with pregnancy, because it stretched out so much that when you have your baby, it won't continue, like regressing to its normal size. So then if the patient tries to get up, the rectus muscles right on the sides, they will contract, but the fascia doesn't have any muscle. So that fascia will just be weak, and then it kind of pops out like an alien, basically. That's how they describe it. But it is not a hernia. It's basically very usual or very commonly in females, and it is a surgical cosmetic procedure. They would recommend physical therapy, but in rare cases, if it becomes really, really symptomatic or patients will start having back pain from it, then cosmetic surgery usually takes care of it. So if you do happen to have a hernia, you can give us a call. You can grab your primary care physician, give him a call, and book an appointment with us so we can evaluate your hernia, and we can tell you exactly what you need to do or what to avoid, or how symptomatic is your hernia. We can talk about it. We might get a CT scan to evaluate the size of it or any other complicating features. What other surgeries do we offer? Obviously, this is mainly for our Facebook friends that don't know about our practice. We offer colon surgeries, surgery for diverticulitis, hemorrhoids, EGD colonoscopies, also lumps and bumps, skin cancer, pilonidals, lymph node biopsies, soft tissue masses, and emergency surgeries. We are here in the hospital, very available Monday to Friday, every other weekend, most likely. Either Dr. Wong or myself will be available here for emergency surgeries, either bowel obstruction, cholecystitis, appendicitis, bowel perforation, and we try not to, but sometimes we do get trauma cases. Also very important to let our Facebook friends know that we did reach 1,000 robotic cases several months ago. The hospital is 113 beds and plus, and it is growing. We are a state-of-the-art robotic, we have robotic technology and suites, and we are expanding for the future as well. So this year, they're already developing the extension for the other tower, where we will have also more surgical suites to get even more cases done and better serve our community. And I want to present Dr. Wong. He is my partner in crime, very well skilled in the robot as well. He does every single type of robotic surgery that we offer, including hernias. And if you like this educational series, don't forget to go back into our Facebook page to then look at Dr. Wong's talk about gallbladder stones, also what to do with them, what to seek medical attention, what are the symptoms, and also he goes through the surgeries and potential complications. And this is our office staff. We are here to help, and we would like to see more of the community, and we have a lot to offer, and as well as Dr. Wong and I, we are dedicated in serving the community and supporting every single care or needs that they, as we can. Yes.
So we have an online question, if you'd like to answer that now. It's from John, and he said, what if a blood clot forms in the hernia?
Usually a blood clot would not just spontaneously form. For example, we would have in umbilical hernias, if he would like to either differentiate which type, but sometimes in the umbilical hernia, we have some protrusion of the omentum, which is basically the fat that covers the intestines and the other organs. If that omentum bleeds for some reason, you could have a small tiny hematoma or a small tiny fluid collection or blood collection in that site. Or I've also seen it that that the appendix is the one that goes through the hole in your inguinal region, and if the appendix becomes incarcerated or inflamed inside of the inguinal hernia, you can have also fluid collections like either pus pocket or just inflammatory tissue. And if that organ bleeds, then we're in big trouble.
That's all the questions we have online.
Thank you. Any other questions here in the room? All right. Well, this is a barcode. So whoever wants to reach us, please feel free to reach the office. This is our address, and we're here to help in any way we can. And thank you for coming.